Hello and good evening, everyone. It's a great pleasure to welcome you to the second webinar of the Swiss Neurogastroenterology and Motility Network, SwissNGM. My name is Lukas Baldiger. I'm a gastroenterologist in training and currently a research fellow in Leuven, Belgium. And together with Daniel Pohl, I am organizing these webinars on behalf of SwissNGM. Like in the first webinar, we have been generously supported by LaserMed, so thank you for their support. After the last webinar where we covered the diagnostic aspects of dysphagia, today we will be looking at different therapeutic approaches, and we have a panel of experts covering all aspects of the therapeutic approach in dysphagia tonight. We will first have all three presentations and then have a joint question and answer where everyone will have the possibility to ask their questions either in the chat or by raising your hand and then verbally asking. Please mute yourself during the entire presentation and question and answers will be, as I just said, at the very end. We will start this webinar with dilation and other non-poem approaches. This talk will be held by Professor Daniel Pohl. He is a staff physician at the University Hospital of Zurich and responsible for the Neurogastroenterology and Motility Clinic and also responsible for the Airport Gastroenterology Clinic of the University of Zurich. And I will now give the screen over to you, Daniel. Please, the floor is yours.
Thank you, Lukas. Welcome, everyone. Really happy to be here today. Also to have Henriette and Heinrich from Basel and Yves Borbély from Bern joining me, so the three of us can both give a short and concise presentation about, as we just said, poem and then surgery, and then I'll talk mainly about dilation. And then obviously discuss, and I look forward to a live and fruitful discussion at the end. So I'll all right. So I'm not going to go too much into didactics, but I would like to start with this slide. I found an old study, which I think very well or nicely sums up a number of things that we talk about today. And this is published in German. It's in the Deutsche Medizinische Wochenschrift from 1973 by a professor of gastroenterology at the University of Marburg, who basically used a pneumatic cardiodilator in 21 patients. And they actually followed them up for quite some time, up to 6 years. And 17 out of those 21 patients actually were, well, with a decent, what they considered a decent symptomatic response without having any standardized questions. And I think it's very interesting to look at this because they basically used a small company in their same city, Marburg, the Kleinschmidt company, to produce a dilator for them, which was, to our standards, quite large, 30 to 50 millimeters dilation. This is nothing we do today. Today, we have the maximum possibility of having 40, and we would never do that as an initial dilation. They later then used an adapted American dilator from Baum-Cardi, which went up to 40 millimeters. So again, they used dilators much larger than we usually use. I do use 40 reflex. The majority of gastroenterologists actually do dilate. A few very rarely do they go up to 40. So interesting to see that you can go up even more. And I think they're also forward to that in the discussion. And that is the term of if you treat patients with dysphagia, what before and after.
Excuse me, Daniel, I don't know if it's just me, but your sound is very delayed and echoing. It's very difficult to understand. I don't know if it's just me.
Okay, I'll try another sound. I get, hold on. Lukas, better now?
Yes, better now.
Okay, using a standard. Okay. So I'll still go forward. I hope could you understand any of what I said or nothing?
The beginning was fine for me, at least. Yeah.
Okay, good. So they also looked at what happened to the sphincter after treatment with dilation, and yes, the pressure went down, which we all would consider normal. What's interesting also was that they mentioned already back then the possibility of having iatrogenic reflux esophagitis, which they found not to be the case in their small dilation series. So a lot of these things we find in larger trials now, but I wanted to show this for the sake of how large of a dilator actually was used in the past, and how long we've had this discussion, what's going on with symptomatic response and what's going on regarding the development of reflux esophagitis. Now, the current treatment, if we focus on achalasia, the current treatment options are basically 3, which are definitive or half definitive. That is pneumatic or hydraulic dilation, and you see here an excerpt of how we do this at the circle. We use the EsoFlip device instead of the Rigiflex device, at least for initial dilations. And here you can see the screen that we then look at on the left side. We have the EsoFlip picture, and on the right side, I'm filming through the balloon here. You have on the same screen the view onto the segment that you're dilating. And of course, you cannot only dilate the EGJ, but you can also dilate the upper esophageal sphincter in pharyngeal dysphagia. You can also dilate strictures. But I focus mainly on achalasia because we all have something to talk about regarding achalasia today. Then there's the peroral endoscopic myotomy, which Henriette will show you in detail, and halomyotomy, and possibly other myotomies that Yves will mention. Now, how do you choose the optimal treatment for your patients? I think this is the main question we face. Now, if you look at the data out there, you find a lot of hits for achalasia and treatment and meta-analysis. However, the question is, which trials do you actually use if you try to compare the success or the methods you want to use for your patients? And again, how do you base your decision on how to treat each patient? So if you do this, and if you compare these trials, you need identical definitions of success. Then obviously, is retreatment permitted if you have a relapse? What is your treatment protocol? Do you dilate once? Do you dilate twice? What size of dilator do you use? How long do you dilate? Then the correct use, of course, of the reported data and comparable duration follow. And there's really three trials that probably should be looked at if you want to look at these questions. And that's the European achalasia study, which was first published over a period of 3-4 years and then 6 years. And I will also present you the latest data, which were just published. And these were 201 patients randomized to pneumatic dilation or laparoscopic halomyotomy. Then there's the POEMA study, which I'd like to discuss because this is something that is being cited a lot, and it gave quite a stir in the community. 133 patients randomized to pneumatic dilation or peroral endoscopic myotomy, and then a German trial by Werner, 221 patients randomized to Hella or Pohl. So these are some of the earlier data when Guy Buxton's first published this in the New England Journal of Medicine in 2011 over 30 months, and he looked at overall the therapeutic success of halomyotomy and pneumatic dilation. And this was basically comparable on a median 2 years follow-up, and swallowing improved in a large percentage of both groups, 90%, using their protocol, which was at least 1 or 2 dilations. They first started with 30, also some men with 35. They later went on to start only with 30 because they did have some perforations in the patients that they started with 30, 35. They also identified some risk factors for failure in those patients, and that were male patients, young patients, patients who were more pronounced, who had more pronounced chest pain, and then the subtype. reflux was here comparable in both groups. Now for the subtypes you see on the right side, the subtypes of achalasia, type 1, 2, and 3, and you can see that type 2 achalasia had the best response, type 1 a little worse, and 3 considerably worse. Now, this is the per protocol analysis. There's also an intention to treat analysis, but I want to show you the per protocol analysis where failures were actually taken out and the intention to treat, everything was included. So it gives a more conservative picture. So if you look at more how you would probably do it from a patient side, then overall it was rather similar. However, the pneumatic dilatation was slightly better, at least numerically, but not a p-value than the Heller myotomy. If you looked at the intention to treatment, they were also numerically basically the same. And this is the continuation study of the Gebuxton study, which was published over a larger amount of years, here up to 9 years in gut in 2016. And then we had the Poema trial, which came out and which surprised it because Poem did expectedly well in terms of treatment success, with roughly 80% of patients responding to a Poem. However, dilation did very, very poorly, with only 41% of patients gaining the symptomatic treatment success. Again, which was quite different from the earlier trial and gave a number of questions. Well, this showed how important the protocol is. If you could look at the protocol of these two studies, you will see that in the European achalasia trial, that it graduated dilation, 30 to 35, possibly 40, and I discussed 40 with you. And patients who had a recurrence of symptoms were redilated with a larger balloon size. So this was 35, or if necessary, a 40 millimeter balloon. A third series, and this was then the last series of dilations, was only permitted if symptoms occurred more than 2 years after the second series. If they occurred within that period, this patient was considered to have failed. But of course, in your practice, you could even dilate those patients. In the Poema study, no redilation allowed, and 16 patients only had a single dilation with 30 millimeter balloon. So technically quite different. Now, these are the very new data from the European achalasia trial, which were now perpetuated from 9 years. This is the line I put at 9 years to 15 years. And this is, again, Heller myotomy against pneumatic dilation. And you see that they are basically the same over this long amount of time. And now looking at the subtypes, this was quite interesting. Subtype 1 was similar. P-value was not significantly different, with 0.7. In the original data, this was the same. For the type 2, pneumatic dilation actually over 15 years fared slightly better than Heller myotomy. This was a p-value of 0.05, close to 0.05. For type 3, Heller myotomy did considerably better than pneumatic dilation over this long time span. Of course, a lot less patients in this group, and that's also the reality of achalasia life, because most of the patients that we see are achalasia type 2 patients. This is the redilation rate, how many patients did need a redilation. Second redilation, 42% of the patients, almost half of the patients, did need a second follow-up after some time to be redilated. A third dilatation over this time, 10%. Now, if you look at the reflux esophagitis, again, one of the topics we tend to discuss a lot. After 1 year, 4 years, and 10 years, you can see in the beginning it's rather similar. If you look after 10 years, you do have you have less reflux in patients with pneumatic dilatation than in Heller myotomy. However, the rate of severe reflux disease, which is reflux grade C or D, is actually similar after 10 years between pneumatic dilation and Heller myotomy. This is own data from patients, and again, this shows you what subtypes of achalasia we have. We have mainly achalasia type 2. These were 28 patients. We published this 3 years ago, or actually 4 years, which we treated with primary esophytic dilation. 21 were type 2, 2 of those had a type 2-like pattern, but normal IRP. 2 had a type 1 to 2, but normal IRP. And again, we have these patients that have a normal IRP, but they look like achalasia, and they do have achalasia, which we then identify on the barium swallow. And 3 were unspecified because the each was very good using a singular isoflip dilation going from an Eckert. Here the barium swallow. Oops. I'm sorry. And here the barium swallow, after 1 minute, 3 minute, and 5 minutes, you can see that the column height went from roughly 5 centimeters down to less than 2 centimeters. And in trials, usually a column of less than 3 centimeters at 5 minutes is considered successful. How about spasm, hypercontractile disorders, and EGJ outflow obstruction? Well, if you look at what they are from a neurologic standpoint, in distal esophageal spasm and achalasia, there's a loss of inhibitory function. Hypercontractile disorders associated with hypercontractility. This can be primary or as a result of outflow obstruction or inflammation. And EGJ-OO really is a mixed bag. However, in general, the treatment approaches are rather similar for all of these. Now, what about diffuse esophageal spasm, or distal esophageal spasm, as we call it now? Very little data. It's not really advocated to do dilations, but here's a series from Guy's Hospital where they referred 1,200 patients for suspected esophageal motility disorders. 5% actually had spasms, so 61 patients, and out of those they dilated 20. Actually, 14 out of those 20 did well. They had 1 perforation in these 20 patients, so that's I mean, 1 in 20 is significant. But anyhow, they did that. I think the perforation rate is too high, but again, the overall number is probably too low to say anything about that. But it's a possibility to do that. There seems to be an effect. But of course, you can also discuss after, of course, having done pharmacologic trials such as calcium channel inhibitors or nitrate donors, you can actually talk about dilation or Pohl. Hypercontractile disorders such as the formerly called jackhammer esophagus or nutcracker, which was the less aggressive version, or generally now what is called hypercontractile disorders with normal peristalsis, probably dilation has no place because you can reach super high pressures within the balloon if you try to treat these patients, and you have a very large segment you want to treat. So if you really do consider disruptive therapy for hypercontractile disorders, then dilatation really should not be a choice, and there's really no good data for it. EGJ-OO, this is a mixed bag of disease, so we're still discussing what to do with these patients. These are some data that were presented in Bucharest just this fall, a few months ago. Amanda Bianca, my fellow, presented these data. We looked at 75 patients who had isoflip dilations. These are the Eckert scores, went down from 4 to roughly about 2 after using a primary isoflip dilation. Again, this is maximum, I believe, with 2-year follow-up. And if you look at the data from available patients where we had barium, yes, the barium column did go down significantly. So it is an option, EGJ-OO, but we need more data. This is more feasibility. So in conclusion, the medic dilation is very much alive if you have the right patients, and the new data which were just published in Gut by the European achalasia trial 15-year showed that for type 2, actually, if you compare the HeLa myotomy to dilation, possibly actually the first choice of treatment should be dilation. And remember, if you do a dilation, you can always go and advance your therapy if you like to a more aggressive treatment. Type 1 EGJ-OO, yeah, you can dilate, but there's also other options. For distal esophageal spasm, possibly in singular cases, has to be an expert center for sure. And if you do this, watch the pressure, because usually distal esophageal spasm is not a high pressure disease. If it's a high pressure disease, careful. Anything hypercontractile, also type 3 achalasia, which is rare, but if it's there, different treatment modalities are preferred. So thank you for your attention, and my pleasure now to hand over to the next speaker. I believe Henriette, you're up next.
Yeah, I think so.
Thank you very much, Daniel. I now have the pleasure to introduce Dr. Henriette Heinrich, who is a staff physician at Clarunis in Basel and is the head of interventional endoscopy there. And she will be talking about peroral endoscopic myotomy, or POEM. And I believe you now have the screen and the microphone is yours, Henriette.
Thank you so much, Lukas. Thank you, Daniel, for inviting me to give this talk about one of my favorite subjects, the endoscopic treatment of achalasia or of dysphagia. I'm going to focus very much on achalasia and other esophageal motility disorders in this talk. I'm going to start out with a little bit of history of how achalasia was initially treated. And to show you the evolvement of care. It starts in 1674, where Sir Thomas Willis reported on the relief of dysphagia by dilatation with a whalebone bougie. So dilatation was already a good option for problems with swallowing. And a little bit later, it was called cardiospasm, which is, I think, a very adequate name for the type of pain that you get in achalasia with a distension and maybe the cramps that you're suffering in type 3 achalasia. And in 1888, Russell performed the first successful pneumatic dilatation. And in 1913, a surgeon performed the first helemyotomy. The term of achalasia was coined in 1927. And it took another 30 years to realize that if you cut the esophageal sphincter, you will make the patients suffer from reflux. So Doran Toupé combined the two techniques with introducing myotomy plus fundoplication. Then people came up injecting medications into the lower esophageal sphincters in the 90s. And then in 2010, a Japanese pioneer, Inoue, performed the first peroral endoscopic myotomy. How many treatment options do we have? The mainstay for achalasia is to make food pass from up to down. You need to relieve the obstruction. This is the cornerstone of each and every therapy you do in achalasia. You want to deplug the lower esophageal sphincter. You can do that with medication or Botox. This usually doesn't last very long. Botox is only recommended in very elderly patients who are unfit for surgery. You can dilate with great success, as Daniel has shown. You can do a helemyotomy, combine it with a fundoplication, or you can use your scope. So there are many, many options of how to treat achalasia. And in the next couple of minutes, I'm going to show you that maybe not a dogmatic worldview on this is right, but a patient-centered, symptom-tailored approach that will make us choose the right technique for treating the patient. So how did Inoue get to that idea of creating a tunnel into the esophagus? This is something that he did because he got into notes, so orifice endoscopy, and POEMS is basically a side product of this. It showed that if you inject into the submucosa will open up and you will create a third space in which to work. This allows for submucosal tunneling basically in almost any organ. It works particularly well in the esophagus, but also in the stomach. And you can close your small incision with just a couple of clips. So POEMS is basically the only surviving remnant of the notes procedures that we saw at the beginning of the 2000s. So how does it work? I will also show you a brief video. Usually the patients come in and they undergo general anesthesia. You want to have patients on your back because you want to know where the posterior wall of the esophagus is in order to decide whether you want to perform anterior or posterior POEM. You create an incision, you create your tunnel, you cut the muscle, and then you close the exit. This sounds very simple and very straightforward, but you can encounter some difficulties along the way. Usually procedure time in masters is between 45 minutes to 90 minutes. And this is also how the learning curve is determined. The faster you are and the better you perform the single steps of the procedure like insertion, tunneling, myotomy, and closure, the less your complications are. I'm going to show you a video showing you the most crucial steps of the POEMS procedure. This was recorded in Milan, where I did most of my training. You can see here an injection with saline and blue, and you see that we really create a nice cushion. We insert the knife quite deeply, and usually what I like to do is I like to use a knife where I can simultaneously inject, so I don't cut too deep. And now I'm already in there, cutting in the third space, very close to the muscle, because that's where I want to go. This is where I want to burn down, up to down. I want to cut the muscle. And what you can see here really nicely is the circular muscle that's not completely open up yet, and the longitudinal muscle that's still there. And that is how the Italians say the perfect way to perform a myotomy. And it needs to be very precise. You really need to be cutting in between those two muscle layers. Although I'm going to show you later, A, it is very difficult and it requires lots of concentration to do this quickly. And B, I'm not quite sure whether it matters for patient outcome. What are the advantages of an endoscopic procedure? You have no scars. You have a tiny scar on the inside of the esophagus, but you don't have an outside scar. It's minimally invasive, and many patients consider it more patient-friendly. Usually patients stay for 2 to 3 days in the hospital. Pain levels are usually highest between a VHS 7 and 8 on the first day and can be treated with normal medication. The Italians use lots of non-steroidal antirheumatics, which I don't use. I just use other medications because I'm always afraid that this will scare my esophageal mucosa. And what is now frequently being discussed in publications is that it could be an outpatient procedure. Some centers in the US perform this as a 1 day in, 1 day out procedure, but I'm very reluctant to do it that way. And what the data also says, and what I'm going to battle about later on with Yves, is whether it is as good as helemyotomy. I'm going to show you some data on that as well. When I introduced POEM in Basel, it was considered experimental. And of course, I did what I always do. I went into the literature to prove that it's not experimental anymore. There have been more than 4,000 procedures performed worldwide since 2010, with a definitive uptick starting in 2013, when it was also introduced in Switzerland by Professor Seewald and Professor Bauerfeind. You have a range of major complications ranging between 1 to 3%. What are these major complications? Serious adverse events. There's 1 death reported from all those POEMs in the literature. There's mediastinitis and there's perforation. There's also bleeding in the tunnel, right in the first 72 hours after tunneling. That requires opening up of the tunnel and sealing of the bleeding vessel. This is a serious adverse event that can lead to ICU stays of patients, but it's luckily very rare. And with new cutting currents and knives, this has become less frequent. Minor complications go up to 20% if you look at the case series. So you very frequently find a pneumoperitoneum that you have to decompress with a needle. You also find skin emphysema, which is always self-treating. It always goes away after 1 or 2 days. You find pleural effusions, you find minor bleeds. What we very frequently see on the second day is a little bit of raised temperature. And this is one of the very few signs that makes me want to perform a CT scan after the procedure. Usually, most centers in Prague, in Hamburg, and in Milan, they don't even perform a barium swallow anymore, which I find very courageous. I'm not there yet. I still do a barium swallow to see whether my clips are in the right place before I let my patients drink on the first day. So it is actually quite a safe procedure in the right hands. So Daniel started out with comparisons. This is a big study from the JAMA in 2019. If you compare POEMS to balloon dilatation, this data of 126 patients after 2 years shows you one thing. You have to repeat balloon dilatation frequently. It has a good response with regard to the Eckert score, but the more frequently you need to perform an intervention, the higher your complication rate is. And also, it is self-explanatory with balloon dilatation, you need more treatment sessions. So when you look at this data, the success of POEMS long-term is 92% and balloon 54%. This data already makes evident what every surgeon loves to tell me is that reflux is the big problem. Yes, in the beginning it's true. And the balloon doesn't have that quite so much. So this paper followed that POEMS is basically in patients who are young and healthy, a good first-line option. I always take that with a little bit of a caveat because the data for the balloon is actually quite good. And I always say, people should do what they are best at. If there's a big expertise for balloon dilatation and achalasia, they should do it. If there's a great expertise with POEMS, people should do that. And if they have both, they should let the patient decide what they want. Looking at comparing HeLa myotomy with POEMS, you can see that POEMS and HeLa have similar success rate. POEMS is a little bit better in the beginning, but in the end, they become, after 2 years, they become almost equal. Also, with regards to the problem with reflux, we see quite severe reflux in the first 3 months after POEMS, which can usually be treated with PPI, and this kind of goes away over time. Patients, about 20% of POEMS patients still need PPI after 2 years. And this is something that leads me to, a very interdisciplinary discussion with my surgeons, because I tell all my patients, if you do a POEMS and you have reflux, there is nothing that keeps us from adding an anti-reflux procedure later on, and vice versa. So this is not a one-way street. POEMS is a third space procedure that doesn't prevent any surgery, and the other way around. Even if a surgical HeLa myotomy, which is usually performed in the anterior, fails, there is still the option of performing a posterior POEMS to alleviate the symptoms of dysphagia. This works really well. What is a little bit more tricky is performing redo POEMS in already myotomized patients. This gives you a little bit less of a success rate. So this is a slide that this is very full, but these are the questions that are being discussed up, down with all the POEMS aficionados. There are people who do very long myotomies. There are people who do very short myotomies because it's quicker. There are people who say you should not, under any circumstances, do full thickness myotomy. It is bad. It gives you more reflux. Also, they say that the anatomy is decisive for predicting reflux? The simple answer is there is no data except for type 2 achalasia, where it has been shown in this large study from Italy that a short myotomy is actually sufficient to give adequate symptom relief. What Roberta Maiselli, one of my teachers, tells me, and she is right, achalasia is a progressive disease. So she favors a long myotomy, so really a 10 centimeter myotomy going 2 to 3 centimeters through the cardia, because if there's still muscle, the muscle can still give you problems. This is particularly true for type 3 achalasia, where the height of the spastic segment on manometry really informs how far up you need to do your insertion and start your myotomy. But if you have a standard type 2 achalasia, a short myotomy of 6 centimeters might actually be enough when you look at the payoff ratio with regards to complications. Reflux. It's a hot topic. This is a study from India, which proposes, and I specifically say proposes, that you actually need pH-metry to say how severe the reflux is. This is a study that was done only in 54 patients. They did a 3-month follow-up. They did questionnaires. They did an upper endoscopy. They did 20-hour pH impedance. And they say that they can predict on the acidification patterns whether people will develop severe reflux. I'm not so sure about this. I think the 20% PPI ratio is in Pohl's patient is quite right, and also that about 10 to 15% will need a second anti-reflux procedure over time. This is something that I would also agree to. So all this study tells me is I need not see my patients after I've done the poems and have seen it after 6 months and they've happily sent me their image eating a schnitzel for me. You need to monitor those patients, but because the esophagus is exposed to acid reflux, and you need to see that it doesn't harm that newly opened esophagus in the long run. So you really need to check those patients in the beginning every 6 months, and then maybe a little bit more follow-up of a year or two to really check whether that esophagus is suffering from severe reflux esophagitis and whether you need to add an anti-reflux procedure to it. How to treat achalasia? This is a schematic representation which I've changed a little bit over the years. I always think you should look at every Pohl's patient, regardless of whether this patient has achalasia, EGJ outflow obstruction, or a jackhammer esophagus, from the perspective of surgical risk. If you have a very, very high risk patient, you should be very careful to do any intervention. This is when I propose Botox. If people don't have a very long life expectancy, I'm not very happy to let them undergo Pohl's. If they have a low surgical risk, I usually propose either balloon dilatation or Pohl. A lot of patients decide for Pohl because it's one and done. If it fails, there is still the option of a myotomy, and if there is severe reflux, you can add an anti-reflux procedure to a performed Pohl. Even if a helemyotomy fails, I've told you before, it is still possible that the endoscopist can help with that. Even if there's a helemyotomy that failed with a fundoplication added to it, there's the possibility that Pohl's can still be performed without the reflux flap having to be opened. I just last week performed such a case. It's technically a little bit more challenging to find your anatomic landmarks, but it's very rewarding because patients can actually swallow better again and have the benefit of a reflux flap already in place. Only if everything fails and the esophagus is very, very dilated, then I would consider esophagectomy. This is basically the last resort. And now a very short comment on the types of achalasia at the end. Type 1 and 2, this is something that I copied from Thomas Rösch, who always gives very practical talks, and I follow those. If the patient is below 50, myotomy, regardless of which myotomy, is the best long-term option because achalasia is a progressive disease. A balloon trial is not wrong. If you have the expertise, do it. And you need to see those patients long-term. Type 3 and EGJ outflow obstruction jackhammer esophagus is something where POEMS is performed, but the success rates are not as stellar as with a conventional peroral endoscopic myotomy. Those patients usually suffer from still more pain, and the failure rates are a little bit higher. It's not completely understood why. And what in these cases is very important to look at your manometry traces to see the spastic segment, where it starts and how high you need to put in your myotomy. And with that, I want to thank you for listening. And this is the picture of the first POEMS performed in Basel. You always have to have a friend standing behind you in case something goes wrong, but you can see from the picture that it went very well. Thank you for your attention.
Thank you very much, Henriette, for this overview. And we will now go over to our last speaker, Dr. Yves Borbély, who is a staff surgeon at the Clinic for Visceral Surgery and Medicine at the University Hospital of Bern, and who is responsible for the esophageal and stomach surgery there. Please, Yves, the screen is yours.
Thank you very much. Also, thank you very much for the invitation. Now, difficult, huh? The worst of the worst for last. But you'll see, Henriette, actually, we're quite on the same track regarding myotomy. So what I'm going to go through is I mean, I'm not going to, the main topic is dysphagia. I'm not going to talk about mechanical obstructions, hiatal hernia, GERD with a typical presentation. So in the end, we're going to focus on achalasia. I just have one really good example of a Sankers diverticulum. But to start with, a word of caution. Achalasia types really are mixed all the time together in the studies. Subjective is not the same as objective follow-up. We heard that before. There's always certain kind of learning curve in the reports, and I'm not really a favor. I don't like the achalasia score at all, and everybody I talk to looks at me quite puzzled. Now I finally found some paper actually backing me up. This really read this. It's a controversy over the Eckert score, which in my opinion in these times is not usable anymore, because I only see overweight patients with achalasia. I don't see the patients that have a weight loss anymore with dietary advice and everything. So I truly think we have to find something else. Just to start with Sankers diverticulum, which also can be addressed minimally invasive or actually interventional. We still do this open. However, whenever possible, we try now to really do this with interventions. And I just want to quickly go. A small example: 80 years old patient, classical and dysphagia for solids, photorexoria, and you see here the picture, and you see here the diverticulum. We always perform a manometry, which actually is quite nice, but you know if you address Sankers diverticulum and you have a bad manometry or actually bad motility, you have less efficacy. So that's why we do this beforehand. But in this case, actually dilation and also the newer POEM methods would probably have gotten us quite far, because this guy had a vascular ring phenomenon because of an incomplete double aortic arc. So this is why we always perform a CT before such a procedure. And just quickly want to show, because you don't see this quite often, or actually me. Then we have, we heard this dyslogical spasm or hypercontractile esophagus, where I think surgery has no place, even though it's possible, but I don't think it's a place there. Now, achalasia. And I typed in into Google Heller's myotomy, and Google knows me so well, 100 years of success. What can I say? Henriette, read this. But we'll see. I'm quite sure in another 100 years, Poem will take over. Sorry, or sorry for me, good for you. Yeah. Just a quick video to see what we are doing from the outside. So we're going up or down to the mucosa just by cutting the muscle. You see this. A little bit of bleeding is actually not a problem. Rather let it bleed than have it stopped because of the fear of creating a perforation. But you see here quite well that we can go down, and now we incise the circular musculature. For surgery, like a surgical option, this really is needed, and I'm going to show you some data. In the end, we do a control with light, so we're really sure that we cut everything. And you have seen it's a long myotomy, like 8 centimeters up, and really important, and we'll see this later on, 3 centimeters down into the esophagus. Then what we see here, they did flip measurements during Heller and during Poem. And that's also the thing. In the beginning, they said, okay, Poem doesn't really need any kind of anti-reflux procedure because we do not really mess with the LES, or actually the distensibility so far, as we see it on the left side, because Heller really, that the extended Heller really aggravates this distensibility index. So you really need this. Clinical data actually proved this, at least for the Poem side, wrong. And that's what we see here. If you just do a Heller myotomy without anything at all, you see here that that's a randomized controlled trial that did some 30 years ago. So 21 Heller myotomies versus 22 plus a door fundoplication. And you can see here that the normal pH studies, after 6 months, they did really functional testing. The pH measurement is ways better. So out of this, even though everybody knew it, it's clear that we have to add some kind of anti-reflux procedure. What type of anti-reflux procedure was for quite some time not really clear, because we had surgeons saying, okay, I do a Nissen, like this 360 degrees, but it's quite clear now that you really shouldn't do this because of dysphagia. After 5 years, you have like 15% of dysphagia, whether if you do just a door procedure like an anterior fundoplication for 90 degrees, it's only 3%, and you have the same kind of reflux control. Again, it would be really nice to have some subtypes or better stratify patients for which procedure. Not really sure if type 1 and 2 really can be distinguished, but also here type 3 really doesn't respond to any kind of treatment really good. Just a quick example, 47-year-old female patient, she underwent, and this is the kind of patients you see as well, not only the typical young, normal, I would even say, achalasia patient, but this kind of patient. And here you really need a combination of everything together. And you also see my concern with the Eckhart score. So she underwent in orthotopic liver transplantation twice, has a chronic kidney disease, is on hemodialysis, has an epilepsy. And for these 2 reasons, so she needs to take the medication for epilepsy and really needs the medication for her liver transplantation. So we really need to have a good flow, I would say, into the stomach for these medication. And she complains of dysphagia. And you always, you start to see the problem here. So this is a barium swallow with a massively dilated esophagus. You can see here like a lake of fluid here, and this here is the gastroesophageal junction before she was dilated. She was dilated like 5 or 6 times because she really had quite an operative risk. But in the end, it really didn't go as well. So we didn't open Heller myotomy, meaning that it really was better afterwards. However, and this I can always say, like in a critical way, the problem is not only dysphagia, the problem is not always really the esophageal part, or achalasia is not only a problem of the esophagus, but also sometimes of the stomach, and that was the problem with her. So she developed upper GI bleedings due to reflux, massive reflux, despite an anti-reflux procedure, and this was her stomach. So she had gastroparesis as well, which we, in the end, did a venting pack and an anti-reflux that would calm the situation, and now she really fares well. But that's the problem, I say, with studies. I mean, you cannot only look at the esophagus. There's always more. Now let's do some comparisons, and I'll share my thoughts on that later on. So versus Botox, laparoscopic helminth versus Botox, obviously ways better with Heller myotomy. However, it might be some kind of patient I would say it's not wrong to use Botox, but in the end, it's clear Heller myotomy is better, albeit with more morbidity. Versus dilation, we heard that before. Not going to go into that because we had this already. Even though, I mean, this was a prospective study, this now is a retrospective, rather long-term study of almost 1,500 patients, and you can see that the risk for pneumatic dilation after, or actually a subsequent intervention after pneumatic dilation is higher than after surgical myotomy. But again, different morbidity. Now versus Poem, and we tend to actually show the same data over and over again. And I'm not even dispute it. I mean, in the end, obviously, Poem is probably even better to treat achalasia for than surgery. Quite sure. The thing is there anything? Is it better in terms of morbidity? What's the learning curve? Or actually, are there any sequelae that we have to consider? And that's actually what we see, and what Henriette already told us. If you follow patients up objectively, you see in this study like a 40% versus 16% acid exposure. You see almost 30% versus 7% esophagitis when performing endoscopies. And I'm quite sure this will even be greater as the more doctors perform Poem. It's the same with surgery as well. Now, where I see surgery as answer is end stage achalasia. Even there, Heller myotomy is possible, and end stage really is like more than 8 centimeters of esophageal dilation. Even in these cases, you can perform laparoscopic Heller myotomy, and it's always esophagectomy as definitive solution. However, if you know the morbidity and also the mortality of esophagectomy, and you still can have dysphagia, like in the upper part of the esophagus, because you're never going to perform a pharyngeal gastrostomy or colostomy due to dysphagia. It might be a solution, however, it comes with a certain price. And I would really say it's a last option in case of failure of other treatment modalities. And that's also what the achalasia guidelines of ISTE state. And just to like another example that we had here several years ago, 85 years old female patient admitted to ICU for septic shock due to pneumonia, obviously aspiration pneumonia. Dysphagia for a few weeks, that's what she told us. Diabetes, actually not that sick, independent, living at home, caring for her husband, but you see here really end-stage achalasia. Solution, it was proposed that, okay, she's so old, let her just not eat anymore, and the problem is solved. But I'm not really a fan of these kind of solutions. So we tried something else. Now you see here the gastroscopy, and you see the manometry. She underwent several dilations. She underwent gastrostomy to feed her, but we really could gradually step up the oral intake. And after about 6-7 months, she ate like normal, and she lived on for 6 years without any supplemental nutrition. So there's like a spontaneous healing of achalasia that can happen also. Now a word to those procedures. Is it really correct to compare these procedures? I truly think it's wrong. Achalasia is a lifelong disease, and I think we better focus on in which situation, which procedure is best. But as it is a lifelong progressive disease, I'm not really sure if one solution fits all. And surgery is always here. It's the last line of defense. But I'm quite sure there are better solutions. I'm quite sure POEM is better if, parenthesis, GERD is a problem, and probably you need to figure out kind of solution. But conceptually, POEM is the way to go, I'm quite sure. In the end, you really have to be able to do it. And this is where I think it might be a problem, because not everybody is really gifted, and you need some kind of patient for the learning curves. So, and there I think might be a role for surgery. Otherwise, I truly think everybody starts with dilation, POEM, and that's the right way. Thank you very much. Open for questions.
Thank you very much, Daniel, Henriette, and Yves, for all your presentations and insights. The floor is now open to share your questions either in the chat or by raising your hand, and we can then unmute you. I will already start the discussion by maybe asking Daniel a question. You mentioned that redilation is often required, depending on the case series, up to 40% in the upcoming 2 years. Now, when I discuss this here in Leuven, people are not very impressed. They are very happy to redilate. But I wonder, how do you discuss this with your patients, the chance of them having to undergo a redilation within the next 2 years?
Yeah, I tend to agree with your colleagues that redilation is not an issue at all. I don't consider this a failure either, although in most trials, at least at some point, you consider this a failure if you inform the patient and the patient is happy to come in. But if you have an ambulatory treatment of a patient, comes in, for him it's just like any upper endoscopy. There's no preparation whatsoever, doesn't need antibiotics. He can go work the next day. He comes in. I actually do an endoflip to measure what I'm dealing with if I retreat, to see am I already starting out at a normal distensibility, or actually was it not? Is there still tight muscle? And then I treat. Then I remeasure. Takes about 45 minutes to diagnose, treat, and retest, and then the patient goes home. And actually, a lot of patients are quite happy to do that because it's rather easy. Also, it's not very expensive. Also, from a cost perspective, there's no hospitalization involved, which is a huge cost driver in Switzerland, hospitalization. And again, for a case 2 patients, I think this is actually the preferred method to go. And again, if such a patient fails, you can always continue on to do either POEM or HELA.
Thank you very much. Please, Dr. Fried.
Yes, I have a question to Henriette. Henriette, you said that first of all, I congratulate you to this excellent webinar. It's really, it was outstanding, very concise, very informative, super. But my question is very simple. Henriette, you said that you decide if POEM is done or a balloon dilatation together with, let the patient decide. You know, the reality is that you must tell the patient what you think is better. I mean, that's always a good proposition, but that's not reality. So I can only tell you what I do. I usually tell the patient I would go for 1 or 2 trials with the balloon dilatation, and if that fails, then I recommend POEM or in special cases a Myotomy. What do you think about that very pragmatic, simple approach from a practical standpoint?
Thank you for this. Yes, I completely agree. This is a path that I very frequently take. I said deciding together with the patient because the patients that I see mostly are young and they're very well informed. They usually have Googled themselves through lots of literature. So what I usually tell them is if you want to have a treatment that sets you up for some time, not forever, then POEMs. If you want to try out what a dilatation does for you, this is also the way. This is what I meant by making a decision together. This usually works quite well, but you are absolutely right. The path most taken is that 1 or 2 dilations are performed and then they say, oh, let's go for something more permanent.
Thank you.
There's no questions yet in the chat. Henriette, I have a question regarding the always fraught GERD occurrence. You mentioned the possibility of doing anti-reflux procedure. I know that Dr. Inoue proposes also doing this endoscopic semi-fund application. Is there any robust data, or is there anyone besides him that can or should perform this?
This is where the polite Japanese Miyagis say that this is something that should not yet be performed in Western centers. Professor Inoue is certainly very capable of performing anti-reflux procedures endoscopically. There are some in India, they started performing TIF after POEMs, which I find very courageous. This is something where I was astounded. It showed quite interesting data. There's also in Europe people that I know that perform ARMs, so endoscopic mucosal ablation of the GOJ after POEMs to create a scar, to contract the GOJ again. I would go to my surgeon to do this. I don't think the learning curve for doing an endoscopic fundoplication is definitely a lot steeper than for POEMs. The learning curve for doing a TIF in trained personnel is not as high, but this has not been trialed in any randomized controlled trials, even for normal reflux treatment. So I would be very reluctant to do that. I would probably go to my surgeon and say, well, could you do a thing, please?
Yeah, please, Yves.
I can only support that. No, but the thing is, I mean, even conceptually, TIF or every other procedure is never gonna be as good as a surgical treatment of GERD because of the hiatal hernia situation. And you simply cannot address this from the inside. Simply impossible. And this is what we have learned quite the hard way since that was actually Nissen's proposal more than 50 years ago, that just do a wrap and everything is fine. And we found out, no, it's not fine. And I just really want the gastroenterological community not to perform the same mistakes as we did, or my grandfathers or whatever did from the surgical community. This really has to be solved surgically if it is a problem.
Yeah,
but I see Michael Fried already raising his hand.
Yes, please, Dr. Fried.
No, I have another question to different topics. So
Okay.
In later.
I can only agree with that, because all endoscopic treatments for reflux are only investigated in the absence of large hiatal hernias, which makes them holistic somehow, then you can, you need to address the physical anatomy, and you can only do that with a surgical approach. Maybe one day we'll find the magic thing to do it, but I would, for the fundoplication, I would go to the skilled surgeon that I know, and I think that's the right way to go.
Yeah, talking about the hiatus, and there's people that say you don't see hiatal hernias in achalasia, and I completely disagree with that. Actually, just today I had a patient, primary treatment of achalasia, and especially if you treat them, the hernia becomes more apparent. And I mean, the hiatus is connective tissue, and I think this is something that also has arrived in the surgical world, that reflux disease is a kind of connective tissue disease, especially if you do have problems at the hiatus. And when we treat this hiatus, whether we do a myotomy or whether we dilate it, at some point we are going to advance age. And yes, we have younger patients, but if they get older, I mean, the prevalence of a hiatal hernia in the general population in an older patient is high. So this is, I think, something that's not being really taken into account yet. But I mean, if I have a patient that already has a 3-centimeter hernia, then I probably either do a hybrid procedure if I do a POEM, meaning I do a POEM and then secondarily I fix the hiatus, or I do a primary hilar, or I dilate and hope his reflux won't be too bad. Because I mean, if you look at all series, then the reflux still is the lowest in the dilation, because obviously it's also the least aggressive one. But what's your take on that? I think that the hiatal hernia thing is completely is not really talked about, and I think it's relevant.
I have to agree with you. There are lots of patients with hernias and achalasia. And if the hernia is large, you just kind of already know in your gut that you will need to call your surgeon in 6 months and say, well, can you help me out? If it's a really huge hiatal hernia, the POEMs is also going to be technically very, very challenging. And this is something that you learn on your curve. And this is something that if you have a good surgeon, they support you in it, and you don't have to make those mistakes. But this is where interdisciplinary management of these diseases come in, where you choose or really discuss the right approach. And this can be highly beneficial, especially in the setting of really large hernias.
You go one step further. So if you have a bigger hiatal hernia, it becomes way easier for the surgeon to perform myotomy because of esophageal length.
Oh.
So I think, and actually every patient I operate on, I see a hiatal hernia, but this might be professional kind of view because I'm a surgeon. But
probably.
Yeah.
What about chest pain? We haven't talked about symptoms, but patients have different symptoms. And one thing is dysphagia, and we can treat dysphagia very well. And then there's chest pain. I took here the stance of being a pro-dilation, and I think I have good data to support that. But if a patient has chest pain, I think this is something where also surgery and also POEMs do more come into play. And I would like to have your guys' opinion on that, because chest pain is, well, if it's from neurodegeneration, then that's difficult. It may not even respond to any therapy. You may use and you may have to use also in addition neuromodulators, which we do, or it's because you need to have a myotomy, which is higher up, right? So Yves, how high can you go up? And Henriette, what do you think is POEMs the first way to go for these patients?
So if you just do like transhiatal, you can go up like 8 to 10 centimeters. But if needed, I mean, you can do this thoracoscopy and you can do a myotomy over the whole esophagus. It's not a problem in terms of technically speaking, but obviously just it's a little bit more difficult because you do thoracoscopy. So it's possible. But just regarding the pain, it's always like every procedure pain beforehand, you have to be cautious. That's just what we learned. For every kind of procedure we do, hiatal hernia, everything, might be some other mechanisms at play there as well.
I agree with regards to the pain. This is why a good workup with manometry and possibly pH-metry is important to rule out functional causes of that pain. I personally, I can still read a manometry, and it comes in pretty handy if I look at spastic disorders, because you can combine a Zenker with a poem nowadays. It's not a problem. You can start pretty high up. It just takes longer, and the longer the intervention takes, the higher the rate of your minor complications might be, but it's definitely possible. I look at the manometric data to see where the spastic elements are, how far up they go, and I think the highest I've done is a myotomy starting at 20 centimeters, so quite high up. There are people who go all the way through endoscopically. I haven't had to do that yet, but it's definitely really important to do that in spastic esophageal disorders.
There's a question in the chat, right? From sorry,
so,
Lukas, you want to read it?
So Dr. Georgia Tutian asks, what are your experiences regarding dilatations for patients with absent peristaltism and sclerodermia, and what about POEM in this situation? And after that question, we'll give the mic to Dr. Fried, who also has a question.
So maybe I can start because it's regarding dilation. So scleroderma, obviously degenerative disease. Usually you have no esophageal peristalsis. These patients tend to have reflux. And as a result of their reflux, they may have strictures in some of these patients. And in those patients, you can carefully dilate, and that works. It's not a disease where you do have trouble at the EG junction in terms of that there should be a muscular component. It's rather then, if there's a problem, it's rather a structural component. So I believe if you do anything in these patients, and I do that because I see these patients from time to time, then you do dilate, but carefully. Use a smaller dilator. I use a EF320, which goes up to maximum 20 millimeter, and that works well. And then I put them, if they haven't been on one, on high dose acid suppression. I don't measure it. It doesn't matter to me how much they have, because they have such a clearing problem of the esophagus that I really want to get the acid out of the equation. So they get a high dose PPI, and I dilate them just where needed. And I would think that Pohl has no role in this, but I'll let Henriette say something.
I've very rarely seen an achalasia in. I have seen achalasia-like images in scleroderma, and there must be achalasia in scleroderma. But the problem with performing POEMs in scleroderma, it's connective tissue disease, and the creation of the third space is a challenge. And I think it is a risky procedure. If you don't have a third space, then it's really, really risky, and you really have to be absolutely sure that you're doing the right thing. So I would go with dilatation in those patients, because you will have problems with your tunnel, you will have problems with mucosal healing. You might not even solve the problem with the myotomy. So I would be very, very reluctant to do that.
And to throw in a break for the surgeons, sometimes you need a fundoplication in these patients or a hiatal repair, although it doesn't last forever. If they have pulmonary complication from reflux, even if you have almost no motility, which is number one, the primary disease, but also because the esophagus gets bathed in acid and anything else. So So that may also be done, but obviously in a center with lots of experience and carefully, and no full rep, not maybe even a half rep. Rep is not so important, it's probably more the high fixation that you need to do. So that could also be an option in these patients. And then if they have dysphagia, then dilate. So Rado has a question, and also, but Professor Fried was there, you said?
Exactly, yeah, that was the next up, was Dr. Fried.
Yeah, very short question to Daniel. You differentiated between distal esophageal spasm and hypercontractile disorders. Is it always so easy to do that by manometry? And the second question is, so what do you do with patients with hypercontractile disorders? There's only dilation? What are you doing with them? I had a problem patient with that.
Yeah. So classically, a distal esophageal spasm, formerly called diffuse esophageal spasm, was renamed because it's really mostly distal. Is based on latency between the swallow initiation and then how the curve goes down to the deceleration of curve. And usually these patients are low pressure spasms, called spasm, but it's really just because of this high speed. So these patients are not too as dangerous, if you want to dilate them, as a hypercontractile disorder. Anything hypercontractile, being it achalasia type 3 or being it something which we used to call the nutcracker or then jackhammer, the more pronounced one, I would be very reluctant. And for those patients, I would always try, number one, to get acid out of the equation again fully. And secondly, I would try a calcium channel inhibitor. You may, as a proof of concept, also use sometimes Botox if you think about more definitive therapy. This is also something that's being discussed right now. Give Botox if they respond well. Consider Pohl or a high halo. This is something that can be done. Dilatation only if the patient super insists on it, and then I'm very careful. I always watch my pressures very carefully when I dilate, so don't do that with a Rigiflex where you don't have any control over what you are doing. You need to do that with a nasoflip if you do that, and you need to do it very, very carefully.
Thanks.
And I think in the interest of time, our last question from Dr. Radu Tutuyan is regarding the learning curve. And the question is, what is the learning curve with Pohl and Heller myotomy? Because pneumatic dilatation can be taught fairly rapidly.
So there's work coming out by the Pohl's Working Education Task Force, which looked exactly at that, what is the learning curve of Pohl's, and it very much depends on whether you have had endoscopic or ESD experience before. If you are a skilled endoscopist who has worked in the third space before, you probably need 10 to 15 cases to be okay. Even if you are a skilled endoscopist, to achieve mastery, there's no actual threshold, and it's never been defined, but the big publications say that you have to have at least performed above 100 before you can start teaching. And this is very true because each poem, even if it says on the tag, it's just a straightforward type 2 achalasia, you can land anywhere. It's still it's a standardized procedure with the same steps every time, but no one can predict how your third space is going to look like, how many vessels you're going to encounter, how much movement there's going to be, whether you hit the right muscles. All sorts of things can be happening. So I would say, even in a skilled endoscopist, you probably need around 25 to 30 to be flying solo. And then you will learn a couple of things on your own. You always do. And I think mastery is probably achieved between 70 to 100. And you need to perform it quite frequently. What also is, I think, mandatory before you start is that you perform up to 10 cases in an animal model, because that is very helpful. to establish the steps for complication management. Usually this is done in pigs. Pigs die very quickly of mediastinal emphysema. They teach you how to perform a careful and very, very precise myotomy. And this is very beneficial for your patients.
And for the Heller myotomy, I think that's not applicable to us gastroenterologists, but what would the learning curve be for a surgeon?
The thing is rather like perform a correct myotomy versus just a myotomy, because you really have to go high up. Otherwise, the effect isn't as good, and you have to go way down in the stomach. And I think that's the point, because everybody can perform a myotomy. So, but I would say 10 to 15 around this, and then you're really proficient and you can do it well. Yeah.
So if I may make one last comment on this topic, because I think this is very important. Achalasia is overall a rare disease.
Yeah.
And I believe, we didn't talk about surveillance here, but I believe that achalasia treatment should always be done in a center where patients are being followed up over also a number of years. I'm now seeing the first patients who were done a number of years with Pohl 8-9 years ago. They come to me because they have relapse. No, they don't. They have stricturing esophagitis, and I need to treat them for that. They haven't been followed up because, you know, people change hospitals and so on and so on. So I think that pneumatic dilation can be taught rapidly. Is it done well? If you look at the heterogeneity of the data on dilatation out in the world, this actually implies that it can be done very wrongly. Also regarding perforation, huge differences between pupils and centers. And again, we are talking about a super rare or rather rare disease. So I think if we have these patients, it's nice that you have still a reflex somewhere sitting and you could use it, but I would really think that such a disease you should give to a center where they also do possibly research on it, and where they have a lot of experience, and they also have something like a follow-up program where they rescope the patient for a number of years and check for some other things. So I think this is also something that we don't discuss much about. Maybe next time or another time, talk about surveillance of these patients.
Couldn't agree more for that final statement. And I think now, in the interest of time, we will wrap up this webinar. Thank you, everyone, for sticking around. If you're still online, thank you also to Isabella Schweitzer for coordinating this event, along with the SwissNGM. Thank you also to LaserMed for their support. Thank you to all the speakers for their excellent presentations. And I would like to give out the information for our next webinar that's planned May 30th on a bit less mechanical topic of irritable bowel syndrome and food intolerances. More infos will follow. If you have any feedback, inputs, any further wishes for upcoming topics, please feel free to reach out at info@swissngm.ch. And with that, I wish you a lovely evening and see you next time.